Welcome to CHEAR Seminar and the beginning of False Spring in Michigan. I hope everyone enjoys the next week. I saw people doing drop off with no coats on, so we've entered False Spring. I am happy to introduce Toby Lewis today. I think you all are very familiar, but I will give an introduction. She's an associate professor in pediatric pulmonology, and she also has a joint appointment in environmental health sciences at the School of Public Health. She her bachelor's degree from Harvard and MD from Cornell, and completed her residency in pediatrics, fellowship, and MPH in Epi at the University of Washington in Seattle. She's a practicing pediatric pulmonologist and is also the director of the Complex Asthma Management Program, MCAMP, which focuses on children with poorly controlled asthma. She's been doing her sabbatical here at CHEAR in kind of different chunks, a quarter here, quarter there, and has done a lot of work with community engaged research around asthma in Detroit also. And so thank you for joining us, Toby, and we look forward to hearing.
Well, it's my pleasure to be here. I have, as Sarah said, I've been doing a sabbatical here at CHEAR to try to develop some new skills in secondary database analysis and learn a little bit more about policy. So I am taking an old interest of mine, which is asthma health disparities, trying to expand my skill set, make some new connections, and I've just really appreciated the warm welcome that I've had here at CHEAR. I am going to be presenting an idea and a project that I've been developing over the last early bit of my sabbatical. I like to treat this a little bit as a work in progress session, presenting to you what I've been thinking about, what I've started working on, but really to try to get the home team to give me some constructive feedback about where I can take this from here. So what I'm going to talk to you about today is promoting equity in patient portal access and usage for children and adolescents with asthma. And advance. There we go. All right, so I'm going to start with just a little bit of background, touching briefly about asthma and asthma disparities. I know Kevin Domkowski has informed you all, but just to orient us a little bit. And then to go into some background about patient portals and how they might promote access, though with the caveat that there may be some pitfalls for equity. Touch a little bit about what I think is the significance and potential impact. Talk about my questions and the approach that I've been taking. I've got some very, very preliminary data on pediatric pulmonary patient portal use that I can show you. Just some descriptives and bivariate analysis, but then to talk a little bit about where I hope to go next, both in terms of my analysis, some new qualitative data projects that I'm proposing, some ideas about intervention, team building, and obviously securing some funding to continue the work, and leaving some time in the end for discussion. I'd love for this to be informal, so if people have questions along the way, please feel free to interrupt. All right, so just orienting ourselves to childhood asthma and health disparities. Asthma impacts over 7 million US children and teens. There are well-described inequities in morbidity, mortality by many different factors, very notably race and ethnicity, income, geography, parent education status, health literacy, and many, many more. This is some recent data, I believe, reflecting 2023 statistics about just the impact of asthma in the US. The 26 million is all patients, adult and pediatric. Like I said, 7 million of those are kids. It's 1 in 10 school-age children. So in an average classroom of about 30 kids, you're going to have 3 kids with asthma. Huge healthcare expenditures, lots of indirect costs related to school days missed and work days missed by both adults who suffer from asthma and adult caregivers of kids with asthma. And a lot of cost, a lot of morbidity, and even mortality. So this figure of a little over 4,000 deaths from asthma was from, I believe, 2022 or 2023. In Michigan, that number was 97 people dying of asthma. So here are some local Michigan statistics. This data is actually really old. This report was published in 2004, reflecting data from the early 2000s. It honestly really hasn't changed. So here in Michigan, we've got disparity by geography. The figure on the left is hospitalizations for kids, showing a much higher rate in Detroit and Wayne County, as well as the Flint, Saginaw Bay City area. Middle panel is about income, higher rates of hospitalization among low-income families. And then the panel on the right is also hospitalizations. This is all ages, but by race, with depending on which data you look at, it's roughly 5 times the rate of hospitalization among Black residents compared to white residents. But to make the point that these disparities still exist, here's more recent data from the State Department of Epidemiology looking at asthma hospitalization by race and age more recently, mid-2000 teens. The darkest bar in the trio is average for all Michigan residents. The middle grade of green is pediatric hospitalizations, and the lighter bar is adult hospitalizations. And again, we're seeing kids get hospitalized more frequently than adults, and there is significant disparity by race. And even more recently, this was a report, this is a headline discussing a report from the American Asthma and Allergy Foundation of America, looking at location, geography, and where in the US is good to have asthma and where is bad to have asthma. And Detroit has the dubious distinction of being number 5 on the worst list. So we still got problems here, despite a lot of attention and effort. And that just goes to the complexity of these disparities and how intertwined a lot of different issues are. And as Sarah mentioned, I've been working mostly in the community and on environment and things that happen outside the health system, but health system issues definitely contribute. And so previously, many different researchers have identified that access to healthcare is a key contributor to disparities. And what we learned generally during the pandemic is how health system factors, including access to healthcare, can synergize or compound social determinants of health. And this is particularly, well, this is also true for people with asthma. All right, so getting into a little bit of the background about portals. Although portals and telehealth has been around in some form for several decades, it was really the Affordable Care Act in 2010 that incentivized the providers to adopt electronic health records with patient portals. And the idea was to empower patients to have access to their data. But as early as 2013, they were already beginning to note disparities by age, particularly amongst the elderly, but also income, geography, both very urban and very rural, education status, race, ethnicity, preferred language. So non-English speakers were less likely to adopt portals. And that was activation, but also in how patients were utilizing these systems. And there was an initial report by the federal government in 2013, a 5-year follow-up in 2018 that showed that the disparities were persistent. And that was before we got to the pandemic. So then, as part of the pandemic response, when healthcare systems had to shut down in-person care, there was a great expansion of services and communication offered through portals. And if you look at the national data about who's connected, a dramatic rise. And so I personally think of this period of, what I'm calling early pandemic, height of the pandemic, 2020 to 2021, as a real paradigm shift in how healthcare services are delivering care. So even though there was an incentive earlier to develop the portals, I don't think the health system was really rolling out care and communication on a widespread basis prior to the pandemic. I think patients and families had to scramble to figure out online access in general for school, for work, for healthcare. So that this was a period of transition. But since then, there's been sort of a settling out. And not just me, many people feel like telehealth and patient portal interaction for healthcare delivery is kind of here to stay. But it's kind of the wild, wild west. Nobody is really sure how it's going to settle out. The federal Department of Health and Human Services developed a health IT strategic plan looking at the period from 2020 to 2025. And in there, they discuss all the wonderful things that portals can do and how this can potentially improve access for people who've historically faced barriers, especially geography, people in rural areas. Yet it explicitly acknowledges ongoing disparities, particularly in access to broadband devices and challenges to usage. So this is on the radar at a federal level. There have been some programs at a national level to try to help this. There is a program called the Affordable Connectivity Program, or the ACP, that's been rolled out through the FCC. And it was funded through part of the Infrastructure Act, but that is sunsetting in April of 2024. So just to highlight that there's a lot of people who have been looking into this. And so there's an emerging literature on the left. I've highlighted work that Sarah Clark has done through the National Poll on Children's Health, looking at behavior of parents, of kids, and how they access or interact with the portal. Key findings are that only 43% of the people polled had activated their portal. So over in the general pediatric population, over half of parents do not have a portal for their patients. In terms of usage, there are many different ways you can use, including for business, what I call the business activities of making an appointment or paying your bill. But what I'm interested in is how healthcare is delivered and healthcare information is exchanged. And so to that point, only, 1 in 3 parents of kids have used the portal to get advice about their child's health. And importantly, parents of teens face some additional barriers. So because of privacy reasons, parts of the medical record are hidden or shielded from parent view. Varies from state to state in terms of what the rules are, but typically it's around age 12 to 13. Parents notice this and feel like it impairs their ability to understand what's going on with their child. For teens, if there is a mechanism for getting independent individual access to their records, but there's extra hoops, lots of confusion about how to do that. And then as you talk about teens developmentally taking on more responsibility for their healthcare in general, especially when you're talking about a chronic illness like asthma, learning how to navigate the system, going from my parent has proxy access when I'm young to now there's a mechanism where both of us can have access, but we see different things, to now it's all on me. At a time when disease can also be changing, teens are starting to smoke and vape, and their physical activity is different. Just a lot of mental health challenges can come up. And so this transition for teenagers was highlighted in the Mott poll, but has also been something that's been raised in other venues here at Michigan Medicine. On the right, I just wanted to highlight that IHPI is very involved in this. There's a whole telehealth research and policy subgroup. Dr. Chad, whose last name I can't pronounce, has been the lead of that team, recently testified in front of Congress about telehealth needs and the future of telehealth. But clearly there is recognition that telehealth is here and we need to be proactive about understanding how our patients are interacting with it and what our best practices are going to be. And then just to highlight that there also has been some work specifically around patient portal usage and pediatric patients with asthma. This is a brief communication out of Children's Hospital of LA, looking at those with activation and those without. So with activation is the dark bar, non-activated users is the lighter bar. They looked both pre-COVID and post-COVID, looking at changes in behavior, but they're linking lack of activation to higher rates of ED visits and hospitalization. This was a very interesting study to me because it very much is the same type of patient population, but LA and the community in LA is very different from what we see in Southeast Michigan. So this study has helped me develop some ideas, but the patterns that they are seeing are not necessarily what we're seeing here. So although there's been some early work in this area, there are many remaining questions and gaps. These are just some that I started with. So are the patterns of inequity that are observed nationally present here at Michigan Medicine? How does portal activation and usage differ for patients that I see in peds pulmonary? And how does that compare to what I would consider the average asthma patient who's seen through primary care? My world is a little bit rarefied, and the types of patients that I see, I think, are qualitatively different than those that get their asthma care through primary care, which is the bulk of asthma patients. There have been some interventions tried in other locations, many in adults, many prior to the pandemic. Would those interventions help here? There are already people working on this here. So what actions have already been taken? Are they being effective? How could or should this be changed? And beyond Michigan Medicine, what's the situation in Southeast Michigan? Like I showed you the geography maps. The biggest asthma burden in the state is in Detroit. Most of those patients aren't seen here. They get their care elsewhere. What about people in the UP? They're not coming down here for their asthma care. What can we learn? That's a population that both potentially could really benefit, but also might have more tech barriers. And then what resources already exist out in the community and how can we link with them? So I pulled out this quote from one article from 2021 that talked specifically about pediatric and adolescent asthma. And it basically just captures the issue, with the sentence. So the dual capacity of telemedicine as a potential mechanism to improve access for some and exacerbate inequities in access for others is identified as a key area in need of scrutiny in pediatric and adolescent asthma. So I took that as my marching orders. All right, so I will say that for me, a lot of this started from personal observations that I was seeing in pediatric pulmonary clinic during the pandemic. As we had that rapid transition over from in-person care to almost complete virtual care, and then the sort of settling out of the pendulum, I saw three patterns of patient engagement emerging. So group one, I would describe as the electronic health record portals, supplements, traditional access. These are patients who've figured out how to activate their portals, use it for communicating with staff and providers for asynchronous use, and have figured out how to use it for video visits or synchronous use, but they also are still attending face-to-face appointments. And I'd say that's, again, this is only my personal observation, that's the vast majority of patients that we see. Group two was the group that I was most concerned about at first. This is what I would call the no or limited portal access group. And these are families that have either never activated their portal or have activated it, but never really figured out how to use it. In general, these tend to be the patients who have other social or financial barriers to accessing care. And they had lower health system engagement to start with, often with higher disease morbidity. And that's the group that I was worried are at risk for being left further behind. And that's the group that I see in our complex asthma management group. They still largely don't have portal access. And what I also noticed is that changes my behavior as a provider in terms of how I interact with them. So wanting to look a little more closely at that and to make sure that we aren't creating systems issues that are exacerbating already present health disparities. And then finally, there is a small group that I saw, group three, that uses the electronic method of interaction to the exclusion of face-to-face care. And these are people who've discovered the portal and love it and never want to come back to the office again. And it's convenient for them. They don't have to worry about catching any infections. They don't have to worry about parking. And as a provider, I worry that they're missing out, that there are certain things that I can do in person as a provider that I can't do well through a video visit. Physically, I'm a lung doctor. I like to listen to lungs and do spirometry, measure oxygen saturation, do some hands-on teaching. And this is a small group, and so far I don't have enough numbers to really look at it, but I think for the future, I don't want to forget about these folks. I'll just say as a provider, I'm sort of agnostic about the benefits of how portals are going to fit into our care plan, but I do think that it's a reality. And I would hypothesize that group one is getting the best of both worlds, whereas groups 2 and 3 are missing out on something and are likely getting less complete care. And then just as I mentioned previously, rules around obtaining adolescent portal access often function as barrier for teens, and that creates some special issues.
So do you know about that group? Do you have any sense of, are they the healthiest of your patients? Because my sense is that there's some self-selection, right? There has to be. People who are the sickest are probably going to continue, my guess would be, to the degree that I don't think that the really sick people would just be in group 3, let's put it that way. I actually don't know whether the really sick people would go to 1 or 2. I can make a story up in either way. But it seems to me that the group 3 are the people who potentially were on the fringe of needing pulmonary care, specialist care in the first place. And I just wonder if there's a way to kind of measure the number of average disease exacerbations, if you have ER visits or anything like that.
Yeah, it's an excellent question. I don't have big enough numbers to really tease it apart. I think I would say people in group 3, in my experience, are the ones that are afraid that they're gonna catch something in the waiting room. That in my clinic, those are the germaphobes. Those are the people who are, yeah, or they're really busy.
They're very far away.
Yeah, our catchment area for pediatric pulmonary is sort of Southeast Michigan, but yeah, yeah, so some of the farthest away people are actually some of the sickest because that's what's motivating them to come all the way to U of M. So that's where it breaks down a little bit. I think, so right now I'm looking at peds pulmonary, but once I expand to look at all kids seen in the Michigan medicine system, I think I'll have enough numbers to be able to look into that.
Although you see kids specifically at Mott, is your clinic at Mott?
So the vast majority of our kids are seen at Mott. We also see patients in Brighton and in Ipsy. So Camp, which is the highest risk kids, is once a month. Used to be pre-pandemic, we were twice a month. Now we're once a month in Ipsy, the rest in Mott. The general peds pulmonary is Mott and Brighton. And then we've got sort of outreach clinics in Flint and Midland. But those are not on the Epic, or not on my chart. So the Midland and Hurley kids are not included in the analysis that I'm about to show you. Oops. So very quickly, starting with some hypotheses, I think the extremes, my hypothesis was that the extremes of portal use, either very high or very low, would be associated with other risk factors for health inequities. For the second one, potential factors that may modify portal use patterns include adolescent age, baseline health system interaction patterns, which sort of goes to your point, and also baseline asthma health status. You might be less inclined to do anything if you're milder. And then the concern is that the extremes of portal usage would be associated with gaps in asthma management care, and that the extremes of portal use would be associated with poor asthma health outcomes. So what are some anticipated outcomes and the significance of this? So
Can I ask a quick question?
sure.
When I see EHR, I usually think of like what you are using in clinic. When you're saying EHR usage, you're specifically talking about
Patient portal.
patient and parent portal use. Okay.
Specifically for interaction with a provider. So
Okay.
not those business functions, but I'm sending a message or I'm doing a video visit.
Okay, thank you.
Thank you for.
So just as a thing, like, so when doctors say they hate the EHR, a big part of what they hate is what she's talking about as part of the EHR. So it's in our heads, it's all not just.
Yeah, but
Right.
it's not, I have to document and I have 10,000 clicks to get through and hard stops on stupid things.
Like you're literally talking about the
Patient portal, healthcare delivered, healthcare information communication.
Okay.
And service provided through the portals.
But usage has like a really broad, right? I mean, I could be getting requesting refills for, your inhaler versus a
Yeah, so.
Video visit, right?
Yeah.
So, and that, so in the National Poll on Children's Health, it dealt with all of those functions. I am not looking at, do I check, I'm a mom at home, do I check my kids' test results? Do I ask for refills? I'm leaving that aside for right now. So I think the goal is to expand access to care, so, and to avoid barriers that may be coming up that are creating a two-tiered system, those that have this kind of access and know how to use it and those that don't. I think understanding who is and isn't using I say EHR, but patient portals is probably more specific, and their patterns of use is important from a healthcare system perspective to make sure that we're providing equitable access, particularly for those most at risk for health inequities or who have other types of barriers, and we're trying to help them address those barriers. And similarly, in the quest to, if I'm specifically thinking about asthma, healthcare inequities, and outcome disparities, I would like to learn how these patient portal usage patterns are helping or hurting, and I would like to turn this into a tool for good as opposed to yet another reason why we have disparity. All right, just whipping through some potential intervention approaches, and this is partly derived out of literature. So certainly working to identify barriers to portal activation. So who are the people who have these barriers? There can be active interventions to connect patients with national resources that subsidize broadband access, like the ACP program that I mentioned. Ability to provide point of care support to facilitate sign up and or a tutorial. I know the social worker in my clinic will sit with patients and in 20 minutes call up kids, get them activated, do a little tutorial. And that's how we've worked it in pulmonary, but I know that not everybody has a social worker that can do that. What about our processes for portal activation? Can we streamline or simplify these and make them more user-friendly? Can we do a better job of engaging patients and families to help us identify better ways to make portal usage and video visit services more user-friendly? Can we partner with trusted community liaisons to address concerns about confidentiality or health system distrust, which is another piece that's been identified in the literature, and partnering with other community-based organizations to give people a location where they can go to access these services, because that is also, it's not just the device and the broadband, it's where can I go and have some privacy to deal with this.
Hey, Toby, so is there an implicit assumption here that if we talk about inequities, right? That implies that portal is good, which it may not be. And I'm wondering if we need to just establish that first before we care about like closing disparities, because
Yeah, so I've wrestled with that. What's chicken and egg, right? Like, so there's one way to look at this is, so there's variation. Who cares? Like, does it matter? Does it have ultimate impact, and is it worth spending our time on? So I totally agree with you, and as I mentioned, I worry that too much portal interaction actually takes away from some of the care that I could provide. So I personally do not assume that all portal usage is beneficial, but I flipped to that is an important question, but part of the way we get at it is understanding who's not using it and who is using it and what are their outcomes. Because if the portal non-users are doing better, that's telling us something about the way that we're integrating portal use into our system. But I think that data that I showed you from UCLA would say the non-users are the ones that are winding up in the ED and are, and so maybe it's just a marker of all those other social determinants of health that are landing those people in the ED, but portals are happening, or services through portals are happening. Health systems, like I see in our clinic, we're doing blast messaging through our portal messages. So if you aren't on the portal, you don't get those messages. And somebody thinks, oh, we should mail this out by snail mail, but nobody has a compiled way, a compiled address list to be able to do that. So it just doesn't happen. So there's communication that doesn't happen. So if that directly addresses.
Can I make a comment? So Kyle, I feel like you're not saying it's better or worse, and I feel like it's a very old school way of thinking about care delivery, right? Because I think sort of the world is trying to move towards like the combination of effective processes of care with patient preference, right? And I think like even when you think about where people fall on the continuum in specialty for care, for example, like there's like, oh, did you get to clinic, right? But I want to acknowledge that, you know, and I want to acknowledge that diabetes is probably particularly germane to this, but there is so much time lost with coming to clinic visits. There is so much opportunity lost with coming to clinic visits such that like we're using a continuum of like in-basket messages, telephone calls, e-consults, right? Like in-person care and virtual care. And I'm not sure that we can say that it should be one standard for all. You know, and I mean, I think like the problem is that you're right, like the super highly capable families, like they know how to use it and they leverage it. And so then having a portal is associated with really great outcomes. So we can't say that it's causal, but I also think that we can't, like we have to think about different ways of measuring preference as it relates to the care, because that's an important sort of barrier that is dropping now because of the technology. Right? So
Well, I mean, I'm agnostic to this. I'm not saying it's good or bad. I'm just like, you know, if we're gonna use the word inequities particularly, if you were to use the word differences, that's one thing, right? If you use the word inequities, that implies that there is a gold standard or there's something we should be shooting for. The economists would say, right, revealed preference, right? People who are not using the portals, right, have revealed their preference not to use the portal. And to your point, maybe that's what they want. So why are we trying to basically push them to use the portal? So and again, that may not be the case, right? Maybe not using the portal is a function of access barriers, and it probably is, and literacy and no broadband. And there are some other aspects of it. I think part of it is the language, and then part of it is also just there needs to be, like, as a first step, I think, some sort of quasi-experimental kind of analysis showing that introduction of the availability of the portal was associated with changes in, you know, healthcare utilization among people who are at high risk, and it improved their ED, whatever, reduced the number of steroid courses or something like that. For me to really believe that this is some sort of thing that we need to be striving for.
I kind of think a little bit more nuanced again, which is perhaps the way that your complex, more vulnerable patients who are not engaging with the portal would find value from the portal would be different to the way that your early adopters who are all over it would find value through the portal. So maybe not that is it effective or not effective, but how is it effective? And should we be assuming that the way that our higher income early adopters find value through the portal is the same way that this group who are not engaging find value? And maybe I kind of think there might be more of a co-design piece there about, rather than imposing this is how a portal works and this is how a portal will help you, like technology is here to stay. How can we design it to meet needs of these families that are not engaging? And once again, if we can build in a high enough value to that system and I guess be helping them with the access issues, it's for everyone, but does it have to be the same for everyone? And do we need to assume that everyone meets the system, how the system wants to behave? Like, so.
I did not plant you in the audience, but that very much goes to why we're planning qualitative work and why we're developing some networks of stakeholders
And
to
it might
try
be
to.
higher order needs, right? You've got a lot of risk selection here. Like maybe people have higher order needs that are not met through the current, whatever the
Right.
portal's giving them.
Yep,
I do think that we're talking about whether a thing works or doesn't work and whether it can, lead to better or worse care. But I do think that whether it's known whether a thing works or not doesn't mean that it cannot contribute to systematically providing differential care across peoples. And I mean, you've alluded to that very point, like that actually, like your access to technology and literacy may mean that a thing that may enhance or worsen care or differentially enhance and worsen care in different populations can't still contribute to systematic delivery of differential care or enhance and amplify those differences in cares across those populations. And so I do think that work that understands whether it does or doesn't do that is valuable, regardless of whether actually the portal is an enhancer of care.
And to me, this also leads to thinking about access to care as more than just availability, but, acceptability, affordability, those things. And really, I think sometimes when we have this conversation about portal access, we just think about, do they have it or do they not, versus thinking about the full continuum of what access to care actually means.
yeah, I just wanted to, the natural experiment that you were talking about is a little bit captured in the first two panels here. So those are the ED visits pre-COVID, when they're really the absolute number of portal activations was actually fairly small, to post, they call it post-vaccine, but post COVID. And the dark bar is the activated users. ED visits went down. Again, is it causal because they had their portal activated? I don't know, but during that same transition from pre to post, those without activated portals went up. Yes.
I think to summarize this, the key is whether or not this is causal, right? Like, yes, it's associated, but it could just be different populations of people with very different, patterns of care or a lot of different things going on, not necessarily a causal effect.
Yes, and I hesitate to say that anything in asthma is driving that there's a one-to-one causality, because everything is so interconnected. But just in the interest of time, I'm gonna quickly,
Sam, is that on yours?
talk about the preliminary data that I have from Pete's home. And this was basically descriptive work, pulling data from my chart to look at the patients who are seen at U of M, pediatric pulmonary, and look at who's got their portal activated and how are they using it for direct interactions with healthcare providers, either through direct messaging or video visits, and to evaluate for, let's call it variation or differences in service access by socioeconomic factors and disease factors. Looking at kids aged 2 to 21, and looking at the period starting in January of 2022, just because some of the dust had already settled in terms of the rapid expansion at that point. And I limited analysis to those who had at least 6 months of observation, just to give people a chance to have time to interact with the portal. And thanks to Joyce and Joyce's team for helping me get access to this data. Yay, Joyce. Okay, so the cohort of kids that I'm looking at is 2,248 kids seen in pediatric pulmonary during this 21-month span. ranging from 6 months of follow-up up to 21, but most had already established care with pulmonary prior to the observation period. Average age is around 9. I've divided it up by age group, looking a little bit at this teen issue, and basically roughly a third of our patients would fall into those teen years, and 10% are technically young adults, but still getting their care with us. Slight male predominance, which is typical in the pediatric age range. Sex distribution flips once you get to the adult age range. I did go to Gary's talk last week and realized these might not be the best way to look at race and ethnicity, but I've characterized it this way because that's how a lot of the national data is presented, looking at white non-Hispanic, Black non-Hispanic, and then pooling Hispanic of any race. And then usually the other or else category is a hodgepodge of things. This includes multiracial and missing data. I would say our race ethnic distribution is relatively reflective of the general population that's out there. Higher incidence of or prevalence of asthma in Black non-Hispanics in general. So national prevalence rates are around 6 to 7%. In Michigan, it's 8% of the total population and 15% of the African population. Very much an English-speaking group that we see in pulmonary. Roughly a third are Medicaid. Many of our patients qualify for Children with Special Healthcare Services supplemental insurance. And my hypothesis is that might be a mitigator. It might help give people extra resources. And about 13% live in a rural zip code. We also linked to neighborhood level indicators of affluence and disadvantage through the NANDA database, the National Neighborhood Data, getting the acronym. These, I believe, all work on a scale of 0 to 1. For affluence, higher number means more affluence, and in the disadvantage, 2 different disadvantage measures, higher number means more disadvantage. So in general, here in Ann Arbor, we see a less disadvantaged, slightly more affluent population than say might exist in Wayne County. For future analysis, I'm going to focus on the affluence because that's where we have the more variation. There's just less variation in our disadvantaged variables. All right, so looking at the asthma characteristics of our population, not surprisingly, in pediatric pulmonary, 67% are going to be moderate or severe. We've got the sicker patients. 30% of those patients see a primary care doc here in the U of M system. And interestingly, almost 60% have other specialists at U of M. And that made me really stop and pause because, again, I don't think that's representative of the average kid with asthma out there. I think that people that come to U of M come because, well, they're either very local geographically or they've got complex medical needs and that's what sends them here. So as I'm developing this, it's important to me to develop partnerships with people outside of U of M to make sure that I'm getting a more sort of representative, generalizable view of what's going on.
Just to clarify, this is not all kids with asthma. This is kids with asthma who are seeing a pulmonary specialist.
Pediatric pulmonary at
So that's
Michigan Medicine.
Right.
Yes. Yes. And that's my point is this is the select group. There is a known overlap between obesity and asthma, and that is very much present in our population. The CAMP program that we mentioned is about 10% of the whole U of M pediatric pulmonary group. The number of kids we follow varies, but around 200 is about the right range. So that's just sort of an internal validation of that number. And as I mentioned, we're mostly based at Mott, but we do have some patients in other locations. Again, these are very sick patients that come to pediatric pulmonary. 13% of them have had at least one ED visit in the last 21 months, and 10% have had at least one admission. We definitely have some frequent flyers who are having multiple of each. All right, I'm looking at the clock and I'm gonna flip through some of this data really quickly. Let's see, all right. Just focusing on that middle bar, who has portal access and what kind of access do they have? I've broken it up by age category, but if you just look at the overall section, 12% of our patients do not have portal access. And at the bottom, 80% have used it, so 20% have not used it. So 12% can't use it because they don't have access, but an additional 8% have the access, but haven't touched it during this project period. In terms of messaging, 85% of people are using it for messaging. That's the top row. And if I go down to the bottom row, about 46% are using it for a video visit. And this is e-messaging to any provider, not just to peds pulmonary or a video visit with any provider, because I was looking at like, do you use it or don't use it? I wasn't specifically focusing in on your asthma care. All right. Very quick view, looking at activation by different sociodemographic factors. If you just scan it, you can see that yes, all of these different factors are association. All of them except for age and gender are associated with activation patterns. This is video visits. Similarly, lots of different factors are associated with video visits or not. This is specifically focusing in on the race question. The order of these categories is a little bit arbitrary, but and these are chi-split, so they're not looking at, I can't say with definitiveness at how one of these groups compares to any other, but scanning the patterns, it looks like in general, the non-white groups have less access and are less likely to be using the portal. Same patterns if you look at insurance type, those with Medicaid are less likely to utilize have access or utilize it. Affluence, neighborhood affluence, so not just, so if Medicaid status is an indicator of the family's income, this is looking at affluence of the neighborhood. So there are definitely some social determinants of health that are influential. I will skip my multivariable analysis, but basically just to say my next steps are to look at this in more detail with multivariable modeling. I'm hoping to expand the analysis to all pediatric patients with asthma here at U of M. Get into a little bit more that true equity issues in terms of the services that are provided and to see the differences And then to your point, we've got two different qualitative studies that we're proposing. The first one is generally looking at parents of pediatric patients who identify as low or non-users and try to understand value and what are the barriers and do they want this? And we're assembling a team of people throughout Southeast Michigan. And then I have a group of people who are specifically interested in the needs of adolescents and young adults, including Terry Bravender, who is the head of adolescent medicine, and Denise Anthony over at HMP. And we're hoping to do some focus groups with teens. And then I'm gonna start hopefully working with Peach to look at how do we translate this information into action, what quality improvement needs to be done, and how would we design an intervention to do so. And just briefly wanted to thank all the people who've been really supportive and helpful, many of whom are in this room and many outside, and just thank you for your time. And I realize I am at time. Speaking about your screen. Skills. Yep.
And then you've got your causal study, right? So can you design it to change their outcomes, for people that don't currently use it? Like,
Toby, are you gonna look at in your qualitative study, are you gonna look again strictly at your peds pulmonary group, or are you gonna have some of the primary care representation as well?
So the qualitative studies are not peds pulmonary based, so the general pediatric population is designed to be more Southeast Michigan. So there's, I think, roughly a third of the patients will be recruited through U of M. Generally, I'm looking for a healthcare system partner in Southeast Michigan for another third of the patients to get an alternative view of another system, and then roughly a third of patients will be community recruited through community means. And then the adolescent medicine one, we're still designing it, but there is an adolescent medicine or a teen health advisory group here at Michigan Medicine that is linked to a national network of teen advisory panels. And so depending on money, it'll be either U of M broadly or we'll try to link in with the national.
Thanks, Toby, for joining us. I'm sure that we all will see you over the next week or so and be able to engage with you more about this talk. There's a QR code. The link is online in the chat for those. And thanks so much.